Hello, I am Khalid Mumtaz and I am working as a transplant hepatologist at Ohio State University Weissmann Medical Center. My job here in the field of liver transplantation is to manage patients with end-stage liver disease due to various etiologies. I see patients who have acute liver disease. I see patients who have chronic liver disease and sequela of chronic liver disease in the form of cirrhosis of liver and its various complications. I also assess patients with advanced liver disease who are candidate for liver transplantation. I'm also involved in assessment of donors for live donor liver transplant at Ohio State University. Patients with cirrhosis of liver develop different complications, including ascites, which is accumulation of fluid in the belly, hepatic encephalopathy, which is manifested in the form of confusion, disorientation, and even coma. Patients with liver disease also develop liver cancer. We call that as decompensated cirrhosis. Decompensated cirrhosis are usually assessed based upon their MELD score for their severity. MELD score is a score which is based upon the liver function test and the kidney function test. This score ranges from 6 to 40. Once a patient's MELD score reaches to 15, there is a benefit of liver transplantation. The score is helpful in predicting 3 months mortality without liver transplantation. Once somebody's MELD score reaches to 15, there is a 10 to 15% chances of dying within 3 months without a liver transplantation. When the score reaches to 30, there is a 30 to 40% chances of dying if they are unable to get a liver transplantation. There are two major ways of getting a liver transplantation for these decompensated cirrhosis patients with high MELD score. One is deceased donor liver transplantation, where we get the liver from the deceased donor and give it to the patient who is on the wait list with highest MELD score. Other way of getting a liver transplantation is live donor liver transplantation, where we ask our patients or the recipient to bring their own donor, and then we can arrange a surgery after the assessment of donor for the donation process. In the United States, approximately 95% of transplants are performed with the help of deceased donor liver transplantation, where liver is procured from a deceased donor and allocated to a recipient with high MELD score. In approximately 10 to 15% of the patients, the MELD score is low and not reflective of severity of liver disease. In those situations, live donor liver transplantation is a useful modality in patients with decompensated cirrhosis and low MELD score. Live donor liver transplantation has also benefit of avoiding waiting on a wait list for an offer for deceased donor organ. Live donor liver transplantation can be offered before a patient gets too sick to get a transplantation. Principle of the live donor liver transplantation is based on the fact that liver has capacity to regenerate and achieve full size and function capacity in the donor and recipient in approximately 3 months. Currently, approximately 14,000 patients are on the wait list for liver transplantation in the United States. Approximately 7,000 patients get a liver transplantation every year from deceased donor. This means that the rest of the patients have to continue to wait for an offer of a deceased donor liver transplantation. Those waiting will get sicker and may not be able to get a liver transplantation. Approximately 1 in 5 patients, that is 20% patients, die while they are waiting for a deceased donor liver transplantation. Therefore, the need for living donor liver transplantation in United States is evident based simply on supply and demand of deceased donor organ. Live donor liver transplantation is a successful option for liver transplantation and provides option of getting a liver transplantation before a patient getting too sick. Live donor liver transplantation is the major source of liver transplantation in majority of Asian transplant centers, including China, Pakistan, Japan, South Korea, India. However, only less than 5% of the transplants are performed using live donor liver transplantation in United States. This proves the point that this source of transplantation has not been tapped appropriately in this part of the world. In order to be a good candidate for a live donation at Ohio State University, we consider a donor who is generally healthy, without any chronic diseases such as diabetes, cancer, hepatitis, or HIV. The donor must be between 21 to 55 years old and must have the same blood group as the recipient or blood group O, which is considered a universal donor. Live donor candidate has to undergo a series of testing, including blood work, imaging of the liver for the assessment of anatomy of liver and its vasculature. The donor has to be seen by our transplant team, including hepatologist, transplant surgeon, coordinator, social worker, donor advocate, and other team members. We make every effort to ensure the safety of the donor first and benefit to the recipient. Hello, I am Mumtaz.
Hi, my name is Dr. Sylvester Black. I'm a transplant surgeon here at the Ohio State University Weissmann Medical Center. My job at Ohio State is threefold. As a liver transplant surgeon, I first have to evaluate patients prior to surgery to determine their suitability for surgery. This occurs with both the donor and the recipient. Second, I lead the team that performs the liver transplant operation. And third, I follow patients afterwards for a period of a year to make sure they recover fully from their operation. The question that we get often is, what is the difference between a live donor liver transplant and a deceased donor liver transplant? A live donor liver transplant essentially takes part of the liver, so up to 70% if we're taking the right side of the liver, or 30% if we're taking the left side of the liver. That smaller piece of liver, though, will regenerate in 6 to 8 weeks. So the deceased donor transplant takes the entire liver, so 100% of the liver. It's a larger segment of the liver, and the liver doesn't need to regenerate post-surgery. So you get the full benefit of an entire liver. However, the outcomes are actually as good or better with living donor transplantation. So when we look at a patient in the pre-op situation where we're looking at the images that we take and we get CT scans and MRIs, we're able to actually reconstruct the liver and do a three-dimensional simulation of the liver. And as the surgeon, I'm able to see all the different blood vessels and the bile ducts and know exactly where to cut. And depending on the way the anatomy is, and everybody's anatomy is slightly different with living donor surgery or with liver surgery in general, that we're able to decide if the anatomy is more suitable for a right lobe donation or a left lobe donation. We are trying to minimize risk to the donor to make the operation absolutely as safe as it possibly can be. And so looking at the anatomy, whenever the anatomy is favorable, whether it's for a right-sided donation or a left-sided donation, that will dictate what side we choose. The risks for a living donor are the same as any major liver procedure, and that can include mainly bile duct complications. And the bile duct is a tube that drains bile that's made in your liver to your digestive tract to help you break down fatty foods. And that's the area in liver surgery that can be injured when you have to basically split the liver in half. This is a very, very minor risk as we take a lot of pictures in the operating room to ensure that we're being safe. The patients tend to recover very, very quickly. They're out of the hospital in 4 to 5 days and back to 100% within 8 weeks. The liver grows back to its full size, or about 95% of its size, in 8 weeks' time. There are no restrictions after 8 weeks. The lifting restrictions occur within the first 8 weeks, where we don't want you lifting anything heavier than 10 to 15 pounds. The process for donor surgery and recipient surgery is that the donor goes into the operating room slightly before the recipient. After the donor gets the appropriate medications, the donor is put to sleep, and we start the operation by making an incision, usually up and down along the midline of the abdomen, and we expose the liver. We take pictures of the liver and make sure all the anatomy is actually correct before proceeding. And then we bring the recipient and we stagger the operations by about an hour to an hour and a half. And then once the recipient is in the operating room, we start to split the liver in half. And then when the recipient team is ready, we take the liver out of the donor and bring it over to the recipient room to start the implantation part of the procedure. The whole operation takes anywhere from, counting the donor and recipient, 4 to 6 hours. The recovery time after surgery is pretty quick. The donor is essentially eating solid foods by day 1, walking the hallways by day 1, and then generally by day 4 to 5, they're able to go home. They come back to see the surgeon in clinic once a week for the first couple of weeks, and then once that happens, then they follow less frequently. We do get labs in clinic and make sure that the liver function is excellent, but most donors recover fully by 2 months. Living donors live just as long as people that have not donated, and in fact, there are no significant long-term health risks with living donation. Recovery for the recipient after a living donation procedure is essentially the same as it is for a deceased donation procedure. It generally requires about 7 to 10 days in the hospital. You follow up in clinic after you're discharged from the hospital, usually on day 10, once a week for the first 3 months, where we adjust your immunosuppression medications to make sure that everything is within the appropriate therapeutic ranges. The long-term outcomes are actually slightly better from a live donor than they are from a deceased donor. And so the survival rates are very, very, very high. And there's a couple of reasons for this. The first reason is that it turns essentially a non-elective procedure into an elective procedure where we can do the operation at the time that's best for the recipient. And then the time that the patient gets the operation, they tend to be much less sick. So their recovery time is shortened. They're able to get back to their full function much quicker. Hi, my name is Dr. Sylvester Black. I'm a transplant surgeon here at The Ohio State.
Hello, I'm Megan Holmesy, and I'm a transplant social worker here at The Ohio State University Wexner Medical Center. Transplant social workers are members of every donor's medical team. When you meet with the social worker, we will complete what's known as a psychosocial evaluation, which is just a fancy way of saying I'm going to get to know you as my patient. I'm going to ask you lots of questions about a variety of different things. During your meeting with the social worker, we'll discuss your basic background information, who the people are in your life that will help you through the process of donation, your work and income, to make sure that being a donor isn't going to place too much of a financial burden on you. We'll talk about your mental health, including any current symptoms or matters you may have been treated for in the past, your current and past alcohol and substance use, your motivation for being your donor, because I want to know your story about how you decided to help your loved one in such an incredible way. And finally, your understanding of the donation process, along with the risks and benefits of being a living donor. As a social worker, it's my job to make sure that you're making an informed and educated decision about being a donor, and that means being aware of the risks associated with donation. The non-medical risks associated with being a living donor include body image, because after surgery, you'll have a scar, and some donors describe feeling differently about their body because of that scar. Financial strain and potential impact on your job. Being a living donor will involve a period of absence from your work, and as the living donor social worker, I can help you explore options and potential impact donation may have on your employment status. Disruption in family obligations. While you recover from your donation surgery, you'll have limited ability for things like driving and lifting, which means if you're a caregiver for someone else, such as small children or elderly relatives, you're going to be limited in what you can do for them during this period, so it's important to plan ahead for this. Substance abuse relapse. If addiction issues were a problem for you in the past, surgical recovery can sometimes increase the risk of relapse. And if pain management was an issue for you, that can be difficult after a surgery as well. Relationship changes. Some living donors describe changes in their relationship after donation, both with their family and friends and with the recipient of the organ themselves. Mood disruptions, because after any surgery, but also especially after being a living donor, it's not uncommon to experience an increase in either depression or anxiety or just not feeling like your normal self. And finally, the impact on future insurability. While you may have insurance now, sometimes the process of being a living donor can change if you apply for a new insurance or insurance policies, and we can help with that. Keep in mind, the majority of donors experience few, if any, of these risks, but the best way to prepare for anything is to know ahead of time and educate ourselves about them. Studies have found that living donors spend an average of $5,000 related to the donation process, and while your surgery, the evaluation, and any follow-up appointments or medications you may be discharged on will be paid for by your recipient's insurance, that $5,000 that most donors spend related to being a donor, that comes from variety of daily living things, because you won't be working, the cost of a hotel, flying, if you're parking or things like that, meal vouchers, all that kind of stuff that adds up. Your transplant social worker will be able to provide you with information on the various resources available to potential living donors to help offset some of these expenses. These resources include applications for need-based financial assistance through nonprofit agencies such as the National Living Donor Assistance Center, fundraising techniques, and organizations which can assist with this process so that you don't incur any fees or difficulties with the money you raise, support groups and online communities such as Living Donors Online. And finally, your social worker can assist you in navigating possible resources available through your employer's human resource department, as some employers provide living donation-specific paid leave and other benefits. Hello, I'm Megan Holmesy, and I'm a transplant social worker here at the
Hi, my name is Robin Peterson Webster. I'm a living donor transplant coordinator at the Ohio State University Wexner Medical Center. My job as a living donor coordinator is to assist donor candidates through the education, evaluation, and surgical process. I educate the donors to make sure they understand fully what they're taking on when they sign up to be a donor. I review all necessary testing with the physician members of the team and then present a summary of the donor evaluation before our selection committee. Once a donor is approved to proceed with donation, I then help that person and the recipient secure a surgery date to move them to surgery in a timely manner. For a person interested in living donation, the first step is to fill out an assessment. That can be done by accessing the OSU Wexner Medical Center website or by calling our office. There is a multi-page assessment form that needs to be completed. It is a lot of information, but that information is very important to us to kind of screen out anybody that may be at risk for donation. So we look through the assessment. We will then contact that candidate. We'll arrange some preliminary laboratory studies to make sure they are blood type compatible and that liver function is normal. Once all these are reviewed and look successful, we will proceed to scheduling a full clinic evaluation. A donor evaluation typically takes about 3 months to complete. We know this seems a bit long to some people, but we want to make sure that the donor candidate has adequate time to reflect upon their decision, to talk with their family, employer, to make plans for their recovery, and for the team to thoroughly review each step of the donor evaluation to be certain this is a safe decision. Donor candidates can expect to be in the hospital for approximately 5 to 7 days. Following your hospitalization, we anticipate an 8-week recovery period. During that time, we will ask that you don't lift, push, or pull over 10 pounds or take on strenuous activities. Following the 8-week recovery, we continue to see you at multiple points throughout the following 2 years. We're going to obtain laboratory studies and imaging to make sure your liver is growing as it should and that your liver is functioning well for you. We do ask that you maintain a healthy lifestyle and stay in touch with the transplant office during your 2-year post-follow-up care. Hi, my name is Robin Peterson Webster.
Hi, I'm Rebecca Kovach. I'm a pre-liver transplant coordinator at the Ohio State University Wexner Medical Center. As a pre-liver transplant coordinator, I serve as the main contact for all of our recipient candidates from the time that they have been referred for a possible liver transplant to the point at which they actually receive their surgery. Being that main contact entails the very beginning portion, which is providing a comprehensive education to those patients so that they have a very good understanding of what to expect from the liver transplant evaluation process, what to expect when they are on the waiting list, and what to expect through surgery, recovery, and the follow-up care post-transplant. So the one thing that I would really like our recipient candidates to know about living donor liver transplants is that truly the process is the same. So whether you are at the end of the day going to receive a transplant from the deceased donor waitlist or from a living donor, your evaluation process is truly no different. If you have just been referred for a liver transplant and just found out that you may need one, if you are active getting testing for the evaluation, or are already on the liver transplant wait list, a living donor transplant can be an option for you. The most gratifying thing for me is to walk a patient who is so sick that they might actually be on death's door through the process of transplantation, and then get to see them 6 months to a year later, and they are as healthy as could be, and out living their lives and enjoying their family and hobbies and everything that they love to do. Hi, I'm Rebecca Kovac. I'm a